I'd like to call to order the City Council work session. It's Monday, December 14. It's now 4:30. Just to remind you, there'll be a regular meeting following the work session at 6 p.m. So as I look around the table, we have a couple missing. I know that Councilman Campbell will not be here. I'm not too sure about Councilman Osborne. Has anybody heard anything? So I'm going to go on. I'm sure that she'll join us in a moment. We have two items on the agenda. The first work session item is to provide an update on the city's capital improvement program traffic signals. Director of Engineering Rebecca Zook and the city traffic engineer Luke Albert to present.
Good afternoon, Mayor and Council. Luke and I are pleased to be before you this afternoon presenting on the capital improvement program for traffic signals. The last time we were before you on this topic was in April of 2015. At that time, we were in the midst of the budget process, and we had an opportunity to share with you some funding needs related to traffic signals. During the budget process, we were then approved for 3 signals, 2 which were pre-identified, and 1 additional signal that was to be determined if necessary as we went through this fiscal year. Tonight, we're going to be providing you an update regarding those 3 signals. I'll hand that over to Luke in just a moment, and then we'll talk about a potential location for a recommendation for a signal at the end of this fiscal year. And then also we'll move into the recommendation side related to as we move forward with the next fiscal year, and some questions I would like to propose to Council for discussion this evening. At this time, I'd like to hand it over to Luke.
Mayor, members of the Council, the first intersection that we're constructing during this fiscal year is the intersection of Yuma Road and Canyon Trails Boulevard. And that intersection, we completed the design in July of 2015, and City Council approved the construction in August of 2015, and we anticipate completing construction in February of 2016. The total cost of that intersection is anticipated at $472,300, or it's actually an estimate. That's the actual cost of the construction. And that includes $67,000 in equipment cost, which is the signal cabinet, the heads, the video detection, all of the smaller items needed to construct the signal. And then the contractor cost includes the purchasing and the fabrication of the large signal poles and mast arms, as well as all of the other contractor costs associated with construction. And then there's approximately $22,000 in city plan review and permit cost as well. And one item of note also is that the design was completed in-house, which saved about $25,000 in engineering design fees. The second intersection being constructed this year is the intersection of Elliott Road and San Gabriel Drive. That one also, the design was completed in-house in July of 2015. City Council awarded or approved the construction contract in October of 2015, and it's anticipated to be completed in March of 2016. The total cost of that intersection is $500,000, with the additional cost being some utility relocation that's needed in order to construct the traffic signal. Shown in this table is very similar to the table that we presented back in April of current intersections being monitored for traffic signals. There's currently 11 intersections on this list. Since April, we've removed the 2 that are currently under construction, and we've also added 4 additional intersections to the list since then. The 3 intersections I'd like to discuss more specifically are the first 3 on the list, which are all either currently meeting or anticipate to meet warrants for traffic signals in the very near future. The first one is Bullard Avenue and Earl Drive. That intersection is currently meeting the 4-hour traffic signal warrants, and we've seen an increase of approximately 10% in the traffic volumes on Bullard Avenue between May of 2015 and September 2015, primarily due to the construction of the new school on Bullard Avenue and also just other area developments. The second intersection on this list is Cotton Lane and Lower Buckeye Road. That intersection is currently not meeting any warrants, but with the extension of the Loop 303 south to Van Buren, we expect a significant increase in traffic volumes, and we anticipate seeing, most likely seeing 3 traffic signal warrants met by 2017. And that intersection also is currently stop controlled on all 4 directions. So by adding the traffic signal, you would improve the flow on Cotton Lane, thereby helping make Cotton Lane more desirable for the trucks traveling to and from the I-10 that are currently using Cerevel Avenue. And then the third intersection list is 135th Avenue and Thomas Road, which is currently meeting the peak hour warrant due to the people exiting Palm Valley Phase 1, as well as the school located on the corner of the intersection, and then the college kind of across the street to the east, and just a decent amount of ingress and egress traffic in that area. And also there's been 2 crashes in the last 2 months that would have been correctable by a traffic signal at that location.
Before we move on to the recommendation portion of this, I did want to propose a potential equipment change for council to consider at this time. For some time, council has been and the city has been installing the modular traffic signal poles and mast arms for the most part throughout the city. However, there are certain locations around Interstate 10 and Loop 303 where our intersections cross the ADOT right-of-way. We have installed ADOT, or what we refer to as ADOT, but they're typical poles that are utilized in other municipalities such as Scottsdale, Glendale, Surprise. They're also used throughout ADOT areas and McDOT. And we utilize those, and we have a few photographs that we would like to share with you. So this is the look of the ADOT pole. They are painted to the city's color. And the one important, I just wanted to throw it out there as a point of conversation. The cost of these poles are significantly less than our modular poles. And so they are approximately 60% of the cost. So as an example, you could construct 3 intersections with this signal pole versus 2 with the modular poles. It would be not simply that we would go to this pole, but I'd like to hear the thoughts of council as potentially utilizing this pole in certain areas, or maybe more specifically utilizing the modular pole in the areas of the ballpark, McDowell corridor, arterial to arterial intersections. So really just to hear from council what their thoughts are on the utilization of a different pole type due to the costs. With that, what we are recommending, based on the studies that we are continually conducting and looking at, we're recommending that the third signal for FY16 be utilized, the funding be utilized at Bullard Avenue and Earl Drive due to the changes in the traffic patterns. One other item, and I can't recall if Luke mentioned this, there have also been 3 accidents at that intersection over the last 3 years. And so not only do we look at the warrants, we look at the traffic patterns, we look at the increases in due to development that is either just been C of O'd or those that are coming, as well as increases such as the traffic volume changes. And then we would also recommend funding for 2 additional traffic signals in FY17. That would be Cotton Lane and Lower Buckeye Road, and 135th Avenue and Thomas Road. And with that, I would certainly like to open it up for comment, questions, and a discussion.
Councilman Bazzillo.
I'm glad you brought those polls up because I have on my notes here, are there other various options involved in putting lights up? And the only reason why I ask is there are times when things come up, as you know, for traffic mitigation that we didn't have budgeted. And my other question dealt kind of with that was, do we have any reserve funds set aside in engineering in case something pops up where we have to deal with traffic and mitigation because of, for whatever reason, that we have those funds available to kind of move forward? All right. Second question is I'd like to explore what you had shown, only because anytime we can expand capacity with the same dollars, I'm always interested in listening. Now, I'm not saying, that's where I would end up, but I think the value of being able to do 3 for 2 in an area where we've got a lot of traffic lights left to put up. And they didn't look bad to me. Now, it doesn't have the fanciness that we have up at Litchfield Road, and I understand that. But with money for resources being limited and whether you can get 3 for 2, I think it's something worth looking at, and maybe not in all areas, but in certain areas, maybe you could stretch that dollar just a little bit further. So I have no problem looking at it and to see where we're going. Again, city permits, I saw that as one of your prices. Is there really value in the city charging us when we put those up, only because it's going from one fund to the other? I mean, it's probably more paperwork moving money back to the city than it is automatically to abate that cost because it's a city project that's going up. Just a thought, because I imagine the labor involved in making the journal entries and whatever, getting it back, as opposed to waiving that fee because it is actually a city project on those permits. I can see the value in that as well. So that's my kind of comments.
Anybody else commenting? Yes, Councilman Osborne.
Oh, thank you. First of all, sorry that I was late. Well, I certainly had read the presentations prior to coming here that you had sent out earlier, and so I understand the reasoning for your recommendation of those 2 lights to be funded. As for the change of the poles, so what you just showed us as a substitute for the ones that we have currently that have the nice, you didn't have I'm going off of what I'm thinking that you're comparing it to, with the kind of nice box with the name of the street and all that kind of okay. So my opinion on this would be, granted, we're certainly looking for ways of saving money, and if we can get more light poles in a quicker time frame by getting 3 instead of 2, I appreciate that. But I believe that we need to focus on which streets we are saying should not have these different light poles. I think that anything that has to do with probably our main roadways, Estrella Parkway, Pebble Creek Parkway, maybe Litchfield Road. I think that we need to identify specifically which roadways we say are either commercial corridors or things like that. My only concern, these would be, simple light fixtures that could be in residential type of situations where we know they're higher travel capacities. But we don't want to sit there and all of a sudden make this change and realize that everything north of the freeway looks a certain way. And all of a sudden we've made this change that really forced a new look on, say, central Goodyear that doesn't seem as pristine or the attention to detail that we're giving in other areas. We just don't want to cause that, oh, you spent this much money on that part of town, but you didn't here. I just want to make sure we don't have that kind of perception, okay? And so that's why I think we need to identify specifically the areas that we're looking at this, so that there's not a cause for concern. And I really think that, in my mind, anywhere that our main travel areas are, we need to stick with the standard we had, because it's a nice looking standard. I know it is more expensive, but if there are ways and areas that we identify can have the less cost, then that's what we do. And it's a strategy, quite frankly. Thank you.
Councilman Loretano.
First, I want to say thank you to both of you for getting that light up in Estrella. People have noticed it's going up. And I don't know if I told you, but a couple weeks after we approved it, a little boy was hit. A 12-year-old boy was hit by a car. crossing that area. He's okay. He was one of my son's friends, but he was okay, went home, just all scraped up and everything. So the people up there really do appreciate it. So I do want to say thank you. And a lot of the public doesn't know that they actually went up there at different times and watched the traffic, that our staff actually went out and did that. And I think that's really important. I'm okay with changing them because when you said Scottsdale, if I remember correctly, around like the Galleria on Scottsdale Road and Fashion Square, it's been the like what you shown there, Goldwater Boulevard, all those roads there. They've always had those up there, and and with the side and the best city, most livable city on the side there, I think that looks just fine. I would like consistency, so maybe if we do find areas like around the mall areas we need more, or I don't know if you could move them to make them consistent or however you do it, but I really do appreciate, because one thing that came to light when we did talk about the Estrella one and we kind of got that one bumped up was we have such a great need for the traffic lights here. And so I really do appreciate the fact that you are looking for other ways, and if it's tastefully done, like I said, I've seen them in Scottsdale and in their high rent areas, so I'm okay with that. So thank you very much.
Councilman Stipp?
I absolutely agree with Joanne. So, and we're going to create a double standard in the city if we start changing this, if we don't have it in pre-identified areas. The feature of Goodyear is it is different. It looks different than every other community on the west side. Our expectations are higher. We just spent an hour last week talking about changing the gravel in the median so it looks better and it lasts longer. So I think when it comes to our community standard, we're talking about cheapening it. And obviously everybody knows where I stand on spending, but in this particular case, this is money well spent. This is the identity of our community. So unless we come up with some determined commercial areas that don't have residential tied into them right now, that that we can move out much farther, and we don't create the double standard, that's the only way that I will support the change. To the the traffic signals, what if we just made that median on Bullard solid and we stopped the cross traffic? Wouldn't that prevent us from having to spend the money on a traffic signal?
I don't understand what you're saying.
Right turn out only from Earl on the east side, right turn only out, and make it a solid median all the way across. We're going to have a traffic signal within a few hundred feet of another traffic signal, and right down Bullard, every street that we have, we have a traffic signal going up at every single intersection. It's going to be impossible to get through this city. We have to stop this. So there's got to be another option besides throwing up another traffic signal. And maybe it's no left turn there. I don't know. And as I'm looking at some of these other ones, I'm just shocked that 135th Avenue in Thomas isn't a little farther up in the need for the warrant. I mean, knowing that intersection and there is no median there, so you're really trying to cross 5 lanes of traffic, or at least 3 to go west over there. I'd like to see that moved up into this fiscal year. We've got a school there, for crying out loud, and then we've got the college that lets out right in that area on top of the church that has a school. And I realize that's in Avondale. Might be a good place for one of these lights that matches theirs. But rather than throwing the traffic signals up in every single intersection, maybe there's other alternatives that we're not exploring yet. And I'd like to know that we've explored every other option besides throwing up a traffic signal.
So I may throw it over to Luke to see if he has anything to add, but I absolutely appreciate what you're saying, Councilmember Stipp. However, for those intersections where we typically would add a median, we have had those pre-conversations during the development process, something to the effect of as future development moves forward and it becomes necessary for us to close a roadway. So it ends up having they've pre-considered that idea of closing it. coming forward at this point in time when it's been open and there's known traffic routes, and that's an expectation of the citizens, it's very, very difficult to close it at this time.
So basically, going forward on all of these intersections that we're creating this problem ourselves, we have no option but to drop traffic lights. Is that that's essentially what you're saying?
There are thresholds for proximities of traffic signals. There are the idea that we typically don't have openings, but every 8th mile or certain things, certain distances such as that, so that we can have control over where access points are. But I do absolutely understand what you're saying. It's not the answer to everything. And just to speak on the 135th and Thomas and us considering that below the Bullard and Earl Drive, again, it doesn't have only to do with one topic. It has to do with the warrants and the specific warrant that's met. In the case of Bullard and Earl, there's continuous traffic. We're at a 4-hour warrant that's met there, and it's heading to an 8-hour warrant. That means there's continuous traffic. Whereas in the case with 135th and Thomas, it's a peak hour at this point. Now, that doesn't mean that it won't extend to the 4-hour, but warrants have different levels of criticalness to them. In addition, like I said, we do look at the accidents that have occurred and what type of accidents are those, and could they have been correctable with a signal. So there are a number of items we look at, and it does include the type of comments that we receive from the public. We've been receiving comments since 2008 and 2009 on the Bullard and Earl. So we're constantly looking and monitoring what expectations we have from our citizens, what type of effects it has on their daily life. Again, the 135th and Thomas, it's only been the last couple years that we've been hearing complaints about that area. But you're absolutely right. There's pedestrian activity there with the school. So it is one that we have been monitoring very closely.
So the Cotton Lane and Lower Buckeye, which meets all of the traffic, 3 of the 4 traffic warrants, we're not even thinking about that until 17.
It'll meet that in 17. It currently does not meet any warrants at this point. Those are projections based on the extension of Phase 2 of the 303.
Geraldine. Councilman Holman.
Well, I just kind of wanted to put my 2 cents worth in, and I'm kind of going to go back a whole lot of years. And I remember when the I-10 signs coming off I-10 into Tempe, and they had changed the stoplight presentation, and it was terribly impactful. I mean, you put those two the 2 pictures side by side, and what Joanne said is right on target. I mean, you've identified this is not, I don't know what you're saying. It's not important enough. It's not our priority. And I think that's a concern. I remember being so impressed by those new stops, those new signals, and was anxiously awaiting until we got some over here in the Southwest Valley. And it's not that many years ago that we got those up. So I support Bill and Joanne in their thinking on that. We would have to be very, very, very careful. And I understand the savings, and that's important too. But I don't want to be penny wise and pound foolish.
Councilman Loretano.
I have a question about the one on Cotton Lane, because you said that would help make the truck traffic, take that off of Saraville. Is that something we would put in before the 303 is completed there, or would we wait to the 303, or would we have to move it? What's the logistics on that?
Mayor Lord, Councilmember Loretano, the 303's starting construction in the spring of 2016. So by funding it in the 2017 budget, we could have the signal construction completed well in advance of the freeway opening in approximately the fall of 2017 is when it would open. So we'd like to get it constructed, installed, operational before the freeway construction gets completed. And the freeway construction isn't coming this far south. It's stopping at Van Buren, and then approximately like about a half mile south of Van Buren is the end of the 8-out improvements. So as far as locating everything, this intersection won't physically be impacted by the freeway construction, just more traffic being sent that way.
Okay, thanks.
Councilman Pasillo, did you have another remark?
No, all I was saying is just to make sure everybody clear on my position, was not to remove or to change our motif, but to put a $500,000 signal in a place where you currently have it there at I-10 where some of those things are getting off, which are 8-out right away, to me doesn't make any sense, all right? There could be some places within the city that will not destroy the look and feel of the city with those type of lights in there. That's the only point I'm making. I'm not saying they should be on Litchfield Road. They should be around going into the mall or some of our areas where we're attracting people in. But you're going to have tremendous demands as we go forward to put up these traffic lights. We don't have $500,000 a pop for putting many up a year. And there's going to be a point in time where you're going to be figuring out, based on your warrants and based on which is less dangerous and more dangerous because we've only got maybe $1.5 million or $1 million to put them in, and that's 2 signals. Then you're going to start wondering, making those type of decisions. So all I'm saying, it's not only dollars. It has to do with there's got to be some places where we can stretch those dollars a little more than on our main thoroughfares. That's all I'm saying.
Councilman Osborne.
Quick question, and I know that I want to say it was a few years ago, we actually had a light that was kind of maybe in storage, and we ended up using it for the Great Hearts Academy that was over there, on McDowell. It was before your time, Rebecca, and it was just kind of amazing that we had this light in storage. But you know, it seems like if there was a way, I know, to say, okay, if we stretch some things and we are able to have a light like the one that you showed, that was the possibility of the substitute as new things came, you know, then you replace that with the newer one, you know, as things go. But it's one that's always I'm going to say it's a traveler, but it's just it's a one that can be used temporarily, just as like you see the old ones that are on the string that you hate to drive under because you think it's going to fall on you. But, you know, it just seems like that would be one of those ones that would be more affordable to have as something that was substitutable occasionally, something like that too.
Yeah, I do
To
remember
fill the
that.
need.
I remember that light, and I remember using it. I also remember you checking into the cost it would be if we needed to rent some, and that's quite expensive. So, and do we still own that light? Do we still have that light? Is that ours? Was it a rental?
Mayor Lord, those poles were poles that we had in storage, but there are standard poles that we just had some stockpiled in storage. So what happened was in order to get that signal constructed, we went into basically it was like our inventory. We went to our inventory and installed that traffic signal, but it was our standard pole that happened to be just some inventory we had in the yard.
Yes, Councilman Pasillo?
Just a follow-up on that. Do you have some of those poles in storage just in case happens to be an accident? Somebody hits one of those poles, take it down. Do we actually inventory some of those poles?
Yeah, Councilmember Pizzilli, yes, we do keep poles in inventory.
Thank you.
Well, I sort of feel like the majority feel the combination of them. I understand the urgency, and especially after the accidents that we've been sent on recently. It's amazing. We're getting more accidents in Goodyear, and they're sending them off to the trauma hospital, so it does concern me. I guess I'm sitting here and trying to look at the transition from the type of light that we're putting up now and that light. I just think it needs to be near I-10, near 303, and I think that meets the look. Would anybody agree on that one? Or is it that you're feeling also you want the same look coming off that?
I'd have to see a picture of it, but I'm always open to exploring.
I'm sure I'm not making you understand what I'm saying. Go ahead, Val.
No, are you asking about, I'm not suggesting we change the ones that are around I-10 or 3.
No.
I'm not suggesting that
No,
at
I
all.
didn't think you did.
Okay. But I'm also very hesitant to change the new ones in the city to that style.
Mm-hmm.
I'm hesitant on that unless we identify a industrial district that we want to put them up in or something like that.
No, I'm okay, and that's what I was saying before. Is if there's certain areas, I do not have a problem because I'd rather get a light up in some of these intersections where there's accidents and have somebody killed. You know?
I guess I'm questioning what certain areas.
Well, I
You know,
think
I mean, you
that's-
gave some of them, but I'd still like to look at an overall picture of, all right, you changed that light. What are you coming off to? What is the next? Where is the next intersection that the other light is in? That's all. I'm just having trouble with picturing that.
So I appreciate all the comments that council has provided, and what I would suggest is that Luke and I take this away and confer with staff and come up with a proposition and bring that back to council for your consideration at that time. And certainly we'll have a map and we'll look at potentially other standards and see what we can do to maybe bring this light signal that I showed you today up to something that might be more acceptable. But then we'll also consider where we can put those throughout the city.
In the meantime, that does give us the opportunity to drive around the city and take a look and actually start looking where those lights are and seeing what the surrounding area is and how we would feel if a different light was set there. We appreciate the information, though. It's very helpful. And the cost, I mean, what can we say? That is much less, and we could do more. So I guess we have to consider that. All right. Thank you.
That's,
Yes.
Mayor, and Council, if I may, so the recommendation from staff right now is Bullard Avenue and Earl Drive, and that will be the one we're undertaking. And while we're not voting on that tonight, it's been a fair amount of discussion, and then the other two that would be part of the budget process for this coming year, the Cotton Lane and Lower Buckeye, as well as 135th Avenue and Thomas. So that's where we're heading right now. Haven't heard anything different from that, although there was good discussion. And then to follow up on what Rebecca had just talked about, it will be, we have 11 intersections here, and I think our focus is to look at those, and then down the road we will have other intersections as we continue to grow as a city, but I think the primary focus is for these 11 first. And as part of that, if you just look at that, 4 of these are actually arterial to arterial, and then 7 could arguably be called collectors and things like that, where there may be an opportunity for a different design. But what we've heard from council is that it really has to be vetted well by council to make sure that we have parity throughout the entire Goodyear community. So
I felt what Joanne said about the neighborhoods, and we always hear this. We always hear the north side, the Pebble Creek side. They usually use Pebble Creek as an example and the other side. And so I wouldn't want to, we do not have and have nots. I don't want to get that in our city. So however we can balance this out so people feel like they're getting the same value as other neighborhoods, then I would be pleased. Anything else? Thank you very much for the presentation. All right. The next work session item is to provide an update on the proposed 6-month pilot project for the community paramedicine program. Chief Louisi?
Good evening.
Hello.
Before we get started, I just wanted to introduce 2 guests that are here. We have Stan Holm in the back, who's the CEO of Abrazo West Hospital.
Hello.
Stan's back
Welcome.
there. And then we also have our Administrative Medical Director, Dr. Gail Bradley, here tonight. She works over at Banner Thunderbird in the emergency department. She's here as well.
Welcome, Ms. Bradley.
Okay. So tonight we're going to talk about community paramedicine and how it really affects us here locally, as well as how others are addressing the issue nationally and across the Metro Phoenix area. We also will review a potential grant opportunity that will fund.
Your mic's not.
Oh, sorry. That will fund. That's better. A regional pilot project, and we would like permission to move forward on that grant application. So again, reviewing the issue, national solutions, local solutions, opportunities, and then time for questions as always. Fire departments across the valley are seeing an increased use of 911 services by repeat customers, so people that are calling the 911 system for help repeatedly. We know that the Affordable Care Act, hospitals are being fined for patients that are being readmitted to the hospital within 30 days of their discharge. And there are 5 categories that they're being fined for. That's congestive heart failure, chronic obstructive pulmonary disease, pneumonia, joint replacements, and acute myocardial infarctions or heart attacks. We also know in the West Valley, west of I-17, 1,261 patients were readmitted to the hospital within 7 days. So not even the 30 days, so 7 days of being discharged. And 60% of those patients were discharged home without any home health care services whatsoever. We got this data through our relationship with Health Services Advisory Group, who is a Medicare-funded company, which helps hospitals reduce those 30-day readmissions. Now that we have a more reliable patient data system, we know that since January, 44 patients have accounted for 395 emergency medical service calls, and its number is growing by the day. We also know that 310 patients admitted to the hospital are accessing the 911 system for help within 30 days of their discharge from the hospital. So they're being admitted to the hospital, and then within 30 days, they're accessing the 911 system for help. We also know that we have 469 patients that have been seen in the emergency department in the last 30 days and now are accessing the system for help. So what is community paramedicine? Community paramedicine helps coordinate the care of the patients that otherwise would use the 911 system or emergency department to help to solve their healthcare needs. It's still new and it's still an evolving model, but essentially it's the coordination of the care or helping people navigate their way through the healthcare system. This always, I know Eddie's back there laughing. It really has gained national attention, more national attention over the last few years. But in reality, it's really something that EMS providers has been doing since the 60s and 70s, going to people's homes to help them. It's really not an attempt, and we don't ever want it to be seen as an attempt to replace other providers. We want it to be seen as an enhancement to the services that are out there. It needs to be team-based in order to be successful. And national studies shows that 66% of the patients that are in community paramedicine programs are referred back to home health care. So really what they're doing here is filling the gap in the healthcare system that exists today. There's many different success stories across different states and even different countries. Canada has been using this program for many years. And a recent article from the American College of Emergency Physicians supports the use of community paramedicines because they feel like fire departments are strategically located throughout the community, but they can also fill that gap that's not being met for those patients. So still in the national landscape, recently the National Association of EMTs completed a survey, and over 100 agencies in 33 states are using a community paramedic environment. One of the biggest ones is MedStar in Texas, which is kind of a quasi-public program that does receive taxpayer dollars, but it's more run like a private organization. But they were one of the first ones to start up this community paramedic program. Dallas, Texas is using theirs as well. Littleton, Colorado Fire Department is using one. In Rockford, Illinois, is actually using a very unique model where they're using a medic, an RN, and a pharmacist to go out and visit the patient's home. So where do all these patients come from? According to the survey, 69% of them come from hospitals. And some of the characteristics of these programs, 75% have the goal of reducing readmission to the hospital. So some of the issues that we're seeing, this is the goal nationally. Also, about the same amount is also trying to reduce the use of 911 system by frequent customers. So locally, what's happening? We've seen some early signs of success in Tempe, who's teamed up with St. Luke's Hospital. So St. Luke's Hospital provides the nurse, and Tempe Fire provides the medic, and they go out and fill that gap. So once the patient's been discharged from the hospital, they go out within 48 hours to see the patient in their home and help them refer to resources. Chandler Fire started their own program. They have a low acuity unit, and they also have a community paramedic unit. They are not working with any hospital systems, but they're going out and visiting with their high-frequency customers. Rio Rico has more of a rural model, but they also received a grant through the Health Resources Service Administration, or HRSA, to develop training programs for the community paramedicine. And then Mesa, within 2 years, has received a $12.3 million Centers for Medicare Services Healthcare grant, that's a long word, or CMS grant. They were one of the only 2 fire departments in the country to receive this grant. So it's $12.3 million. It extends for 3 years. And they're looking at both behavioral health and community paramedicine. We're hoping to get more data from them in the next 18 months once the program and the grant is completed. But early signs are a very, very successful program. Buckeye Fire has started a program, and they are working with Banner Estrella. They've had 109 patients that have been admitted to their program. 45 are still in the active roles right now, but they've only had 1 readmission. So within the 5 types of conditions that get fined by the insurance for the hospitals, they've only had 1 that's been readmitted out of all those patients. And also Scottsdale Fire, they're the newest program. They've teamed up with Honor Healthcare. They're providing a nurse practitioner. Scottsdale Fire is providing the medic, and they go out and they see high-frequency users, but they also see patients that have been recently discharged. So again, a lot of bridges for that gap that's existing in the healthcare, but many different models, but many different success stories. So in the West Valley, this is more of a regional approach. I'm chairing 2 committees right now. One is a regional operations committee for EMS, and the other one is working with that health service advisory group on the West Side Healthcare Collaborative Group, looking at community paramedicine as a fix for those 7-day readmits. So we're looking at a lot of consistency pieces. One of those is how do we define what a high-frequency utilizer is? So we've defined it as 3 or more a month, so 3 or more 911 calls in a month, or 12 or more in a year 911 calls. We're also working to identify minimum requirements for the vehicles, such as equipment. We're working on training, and we're also working on the staffing models as well. And we've come to this point now where we have become aware of a grant application. But it's a multi-pronged approach that is going to require the whole region to really look at. There are 56 different agencies within this group that's looking at this. Here's some of the ones that we know that are around us. We have 2 fire department districts with current hospital partnerships, Buckeye and Banner Estrella, as I mentioned. North County Fire Department, which is formerly known as Sun City West Fire. They just changed their name. And Banner Del Webb. And there's 7 other cities in conversations or in some phases of development. We've also engaged our pharmacy partners, obviously other fire departments and surrounding districts, Sun Health International Medical Direction, that Health Service Advisory Group, as I said. We've also have St. Luke's Health Initiative, which we'll talk about a little bit more. Access actually is coming out with a new initiative sometime next fall. We're very hopeful about that program. And then also Mission of Mercy, which is in Avondale on Mondays, that provides free primary care care for patients that don't have insurance. We've been working with them as well. But again, a multi-pronged approach, and it has to be coordinated. So what is the pilot project? Again, we're working with St. Luke's Health Initiative, which is a nonprofit which helps fund efforts to improve health of individuals in communities in Arizona. So we would go out and proactively visit those high-frequency utilizers, which, again, we already defined, and that would be part of the application project. Also, a needs assessment. Once we get out to see the patients, we would do a needs assessment for them. What do they need for resources? We would provide patient education, help with safety checks, and then help finding other healthcare resources that they may need. We're thinking that a lot of these patients are going to fit into that patients that get fined, so patients at high risk for those 30-day readmissions, so we can provide some support to the hospitals as well. It will require a different platform. We know that we're going to do this on a two-person vehicle, something that was considered back in 2006 in the Public Safety Committee that requested to look at EMS calls from a different platform, not a four-person, but a two-person. So this will really give us a chance to look at a two-person approach to EMS calls. Crew members will be chosen specifically for the program, but we also will be teaming with our regional partners. Right now we have 5 cities that are in conversation: Peoria, Avondale, Sun City Fire District, and also Surprise and Goodyear would make the 5th city to go in that pilot. So through the grant, we would seek $125,000. Right now, our initial discussions with our partners, about 64% of that would go to personnel costs. So a lot of that would go towards overtime to kind of fund a person in the unit for each of the cities. The rest would go, 36% would go to training development, because we know that that's a big piece that's really missing in the community paramedic program is a consistent training program. So a lot of that time would be spent on a training development program and other necessary minor equipment. We would use existing fleet, either a pool vehicle, or we've also been talking to fleet recently about a PDD vehicle that's due for replacement. We would hold it for 6 months for the time of the grant. And all other equipment would come from existing stock that we currently have now. We've also been having other conversations with other healthcare partners, and they're also proposing money in a grant type application that would be provided for us for a year to actually study this, as opposed to the 6 months. So there are other healthcare partners that are at the table right now talking to us about this. What would the staffing model look like? It would have to be a 2-person unit from a safety perspective. But we know there would be one Goodyear paramedic and then another regional partner. So whether that was Avondale or Peoria, Sun City or Surprise, would provide that other regional partner for us. And this is consistent with how the nation is staffing a community paramedic program. About 77% of them are staffing with medics. The other entity would contribute that second resource, so it wouldn't all be on Goodyear. But again, the grant would fund all of the personnel costs for that, and most of the costs for the entire program. So how do we measure success from this pilot program? Like I said, it would be about a 6-month pilot program. We know that the first few months would be on the training development, ensuring that we have the right staff in the vehicle. But a majority of that, 3 to 4 months, would be out visiting patients. We want to establish that definitive training program, further define our cost per call information. We really have to have a good understanding of what that cost per call really is out there for us. Establish and defined outcome indicators to measure effectiveness, so whether we're reducing non-emergent calls to 911. We also want to be able to go back to our hospital partners and show that we can reduce that 30-day readmission. And also we'll be looking for customer satisfaction surveys on all community paramedic interactions. So what are the benefits to the community? It's be fiscally responsible to our taxpayer dollars. Today we know that when a 911 call goes out, it costs us about $23 to dispatch that call, and that's through Phoenix Fire. So we get charged on a per call dispatch. So that's about $23. But we'd also have to learn what are the other costs that are associated with a call. Today we know that a 4-person model costs us about $254 roughly per call. So based on our call volume and based on all of our personnel costs and other O&M costs for the vehicle, we know that it's right around $254. And this is pretty consistent with our partners across the valley. Also, we want to look at what does it look like sending a 2-person crew versus a 4-person crew. And the dedicated equipment to these calls is less expensive than the traditional fire call, 911 fire call. We want to show a decrease in the unnecessary emergency room burdens because this backs up the entire system. You know, if we have a crew that's sitting in the hospital waiting for a bed, other calls are
still continue in the system. So who covers those calls? Are we bringing in other resources to cover those calls? So this keeps our units in their first due or their first response areas a little bit more efficiently. Provides support to the vulnerable population. We know there are patients out there that need help, that may be afraid to ask for the resources or may not know how to ask for the resources. So we want to be that support for them. It creates that public-private partnerships as well. An opportunity to collaborate and to really maximize our resources for the community. It provides outstanding, innovative customer service for our residents. But again, that regional approach will really show a good way of collaboration with our partners, both private and also public partnerships. Some of the challenges that we're just early starting to look at, we really would want to look at a little bit more, is creating that sustainable payment model. We know that at the end of the grant, we're going to see, what really is this type of model? What is best that we have? We've had conversations with Stan and with some other CEOs about really what does that sustainable model look like? Is it a cost per call type basis? Is it a shared savings at the end of the year? How much savings you create for the hospital, and they share some of those savings? I know that MedStar in Texas in the Fort Worth area in Texas is using that model with success. We want to make sure that our other healthcare partners are willing to assist us. I said that there's 56 other agencies that are sitting with that health service advisory group on those committee meetings. And we just want to make sure that they're all along the ride with us. They like the ideas. They've been very encouraging during our meetings, providing a lot of support and feedback. But we want to know that once we get to the end of the road, are they there with us? Regulations from state and federal government. Because it is a very new and evolving model, we want to see where really the state and federal government go. Because it's a pilot project, we do have the support from the state. We've been talking to them from a holistic level that we would like to look at a pilot project from a regional level. And they like those ideas. There are no regulations yet, but we know at some point that those may come. And then certainly we know that there are workforce challenges. We know that this is not a sustainable model for overtime, but what would the workforce look like? Is this something that if a firefighter may not want to promote to a captain or battalion chief's position, that maybe they look at this type of a model as they get older in their career. It's not as much wear and tear on their body, and they're still providing a high level of service for our community. So really, what are the next steps at this point? The grant application would be due January 22nd. We'd have to develop an IGA to share money between the cities. The grant will only pay one city, and then we would share that out with the other cities. We needed to continue to identify key stakeholders and resources in the community. That's one of the things that we've heard from Buckeye and Chandler, that they've created books, 3-ring binders now, full of resources for patients. One of those is when a patient needs their medications picked up at the pharmacy, they found resources to help get that patient there. Or rides to the hospital. They found that Access provides those rides for Medicare patients or Medicaid patients. So there's opportunities out there that we need to maximize for our residents. We need to standardize our data for a community paramedicine pilot. We can't be collecting different things. We have to collect the same information. And currently we're in conversations right now with the person that owns our electronic patient care reporting system that we use. And they're very interested in partnering with us. They have a foundation that they would be interested in coming on board with this grant. Really would not ask for anything, but just to be able to collaborate that data for us. Identify other evaluation partners. And then we would want, at the end of the pilot, obviously publish our results. So whether that's through a local or a national trade journal. I did provide some references for you, and they should have been printed out as well. Those are 3 recent articles on community paramedicine, but I'll open for any questions that you have now.
Councilman Bazzillo.
First of all, I like the concept of anything that can reduce the demand on the actual 911 system. As we grow, if we can reduce that demand, in my view, it'll stretch out the time in which it requires to expand that area. But I got a couple questions as we kind of go forward, and maybe one's probably towards Larry. But as we move forward in this, it would be nice as far as you got a 6-month pilot program, and you're going to look you're going to be collecting data to see the cost, and you're going to be looking at some type of matrix to see how you're bringing some of this down. I think there'd be value in setting up a separate fund, separate division, somewhere where we can actually track everything that's rolling into that specific program, so you know your costs and you know your revenue that's associated with it. The other question I have is with the people that are going to be using this. Are you pulling people who are currently on staff off to run this? They're not going to be tied to your traditional shift. On the big trucks going out, you're going to have some type of equipment you're not going to be bringing the big, huge, fire trucks out there. You're going to have some type of equipment that's going to be making visits to these individuals.
Yeah.
Okay.
Yeah, absolutely. We're going to look at either a pool vehicle that's currently within our fleet or potentially a PD Tahoe that's going to be retired soon from the vehicle replacement program.
Okay, but it'll be somebody internally that you already have.
Yes. Yeah,
so you'll have to backfill that with overtime, I assume, as they go out, right?
Yeah, and this would not start it wouldn't fund until July 1st. So, we would have the next budget year to work with.
You were going to have 2 people making the calls, and I thought I heard you say one from Goodyear, one from somewhere else.
Yes, yeah.
Okay.
So the demand wouldn't be as bad on Goodyear.
On the one side there,
yep.
Okay. You're going for the grant.
We'd like to.
Okay. Because if you don't get the grant, what's your funding source for seed money to get this thing started?
Well, the other business partner really that at the table right now is Tennant, who is the owner of the Abrazo hospitals, amongst many other hospitals. They're the other ones that are talking about a grant. Right now, it's still really in the infancy phase, but they're talking about a similar type payment model where they would make a one-stop payment to us, and then we'd have a year to kind of figure out the project.
Okay, because sometime if you're billing them for the funds, you're going to have to have somebody internally, I guess, track the calls and the visits,
yes.
and then whatever that number happens to be.
Yep.
So you've got the resources to be able to pull that off internally as well. Okay, separate fund. And again, I'm looking forward to that savings because I think anytime you can stretch out those costs is an important thing. I would think the hospital would be very interested because I guess with the new Affordable Care Act, if they end up back in the hospital, I imagine Stan can address that, but if they end up back in the hospital, they don't get reimbursed for it. So there's savings to the hospital. So I would hope they would be kicking into this program because long term there's value to them as well and not having this individual going back to the hospital.
Right, and it's really savings to the entire healthcare system. Right. There's benefit to everybody.
Okay.
Including the people that pay, into Medicare.
Well, it's an interesting concept. And again, anything we can do to stretch it out, I would just like to see it tracked separately so we know when it's all said and done, whatever that project happens to be. We
Absolutely.
know the upside, the downside, what we thought was going to happen, what actually happened, and if there's savings, what those savings are.
And the idea would be for us to come back to you at the conclusion of the pilot and be able to address a lot of these questions with you, really kind of show costs, where the money was going to, how it was expended, what would be the potential for reimbursement for the departments, because more conversations will start to happen. They're happening organically now, and I think they'll continue to happen probably at some point in earnest. And through some of my research, we found that in the state of Michigan, they've been doing this program for a little while. They've actually seen about a 30% reduction in calls to the 911 system because of this program. Much bigger system, but still, they're showing reductions.
Yeah, and to me, that'd be very interesting to see those type of results because with the Affordable Care Act, there's going to be a lot of tweaks as there's more and more pressure put on the hospitals and the doctors and et cetera to find efficient and effective ways of providing quality health care. And again, anytime you can look at something that's, I wouldn't say outside the box, but new and different than what we had in the past, I think it's worth pursuing. At least take a look to see how it would impact us.
Great. Joanne?
Thank you. Well, first of all, I'd like to echo what Councilmember Pizzillo stated. I think that looking at, not in a business model, but in the sense of tracking and understanding how all the money is going in and out is beneficial for us. But I have to tell you that I feel like this is an early Christmas present because for years, I've been looking at this and just, as in background for the rest of this council, as the chair of human services for MAG and chair for homelessness and at the National League of Cities, community paramedicine has come up time and time again in the last 8.5 years that I've been watching this, and many times it is the such a strong answer to impact for a community. And I'm thrilled to see us looking at this. And I understand we're taking baby steps, started as a pilot project, see how this can work for Goodyear, see how our partners can embrace this. I totally get that. I can see how this is a win for our citizens. And, you know, it's one thing to be service-minded for our community, but at the same time, when you look at the fact of freeing up beds in a hospital, in the ER, and you're looking at the efficiency of having a 2-man crew versus 4 going to check on that person that continually uses, you know, the 911 center and emergency center. Those are very, very important to our entire community, and I think that's great to look at. You answered Joe's question about what if you don't get the grant,
Yeah.
so I do appreciate that. But, you know, I also just have to say, because I know we have a few out in the audience, that Georgia and I do sit on the board for the hospital. And so not only have we seen how this affects a community just over the years, but we also see the side of the hospital. And so I can understand how this is a really important collaboration that can benefit everyone involved. And I'm really excited about this. I think that I had one other question. Well, you answered about, you know, you're going to be talking to the people themselves, surveying them to make sure that, you know, this is working for them. Oh, I know what it was. So if this all successful and you start to look at it as a full-blown, you know, program,
Yeah.
how do you bring in possibly behavioral health issues?
Yeah.
Because that's another, you know, growing number that we continue to see.
Right.
And you addressed it a few months ago, so can you?
Yeah. I think the Mesa model will be really interesting to watch and follow. We're also working with Stan and the Health Service Advisory Group to address this through a behavioral health summit. So we're gathering some data right now, and that will happen sometime in February, early February. And we'll start to talk about the issue more regionally and then kind of drill down to kind of locally and what are some of the solutions out there. So every fire department is dealing with this and police department is dealing with this right now across the valley. You know, where do we put our patients? Because necessarily they don't always belong in the emergency department, but they belong in beds. And those beds are scarce throughout the area. But we need to find better solutions for our patients. And just recently, entered into a relationship with a business partner for behavioral health. Not really sure that that's the exact model that we would want to look at, but it's at least something that they're trying to see how successful this could be. Dr. Bradley has been on board with this, and she's impacted by it in her emergency department, as well as Stan's been on board too. So I think we just have to work collaboratively and continue to look at the issue. But, I think Mesa really will be the interesting point to kind of watch and see how they develop their program. So,
Very good. Well, I appreciate that, and I think that that's something that's bubbling at the surface that not everybody hears about, but and not an easy trackable type of thing either.
No.
And so I understand that, and it will be very interesting to see how this rolls out. But I think in the end, it's truly a win for everybody. I appreciate it. Thank you.
thank you.
Vice Mayor Loretano.
I want to thank you for taking the steps to look into this, because I think, like Joe said, this will really help save money all around and provide much better care for our citizens. So I am all for this, and I think it will be a good program. My only concern is, and I know you are trying to start, as Joanne said, baby steps.
Yeah.
But does Buckeye have its own program out the gate? Or,
Yeah.
I mean, how's this?
Yeah, so they've been working with Banner Estrella for quite some time, about 2.5 years. And they finally got to a point where Banner Estrella gave them a group of patients. And it was about 35 to 40 when they first started. And then, as I said, it grew to about 109. It took a long time for them to get to that point, but they did it as a pilot project as well, and their pilot ended at the end of November. So they're working with that health service advisor group to collaborate some of the data and get that published. We're hoping to see something by the end of January. It's the last I heard. But they've had a lot of success, and they've taken some of these numbers, I know, to Stan to show him that the program definitely works, and there's definitely a huge benefit to it. Now, the one piece about the other hospital that we're working with, Tenet, the chief medical officer for them, Dr. Carney, was hoping she could be here tonight, but she actually started this very similar program in Indianapolis. So she's a subject matter expert in the program, but she's also a psychiatrist by training. So she has this behavioral health piece that she really wants to address as well within the program. But I think a lot of these different cities that have gone off on their own have shown early success, but we want to show that I think the regional concept will really work as well. And I think it can have a lot of benefit and is not as much impact on each individual department. So,
And the call volume, how do you get, because you said Buckeye got the patients from the hospital.
Yeah.
Is this something people have to, like they're referred and they have to opt in, or can
Yep.
they opt out, or how does it work?
Yeah, so Tempe and Buckeye are very similar, that they have to opt in. Same thing for Scottsdale. They have to opt into the program. So when they get discharged, the case manager will come to them and ask them if they want to opt in or opt out of it. I don't know what the percentage is, but they get quite a bit that opt into the program. There's a lot of trust factor that goes into the blue shirt. Then a home health agency that just arrives to the door and not sure who they are or where they've been, but that blue shirt gets us in the door a lot with the patients and builds that trust. And maybe if we can then refer the patient to a home health and say, hey, we know them, we've been working with them for X amount of time, that creates that level of trust between the patient and now the new provider. It's not just kept on the fire department as a whole. So.
And as part of the grant, do you write like kind of a next steps for the grant? Like if it's very successful, I mean, is that part of the grant process to say how we could expand it? What would level 2 look like? Or
Absolutely. They're going to be looking for the sustainability model as well. So that's the one thing that nationwide people have been struggling with is how do we make this sustainable? There's definitely some ideas. MedStar has had a lot of success with that sustainability model. But that will be part of the grant is how do we make this sustainable? How do we determine what the cost per call is, or what is the best solution for everybody to come to the table? Think about it. We use Stan as an example because we've been talking about him all night. But can you imagine 9 different fire departments going to Stan and saying, hey, we want money to help drive down readmission rates? That's a lot of money just for Stan. Doesn't seem like a lot of money for the fire departments. So we think that this model, this regional model, is the easier approach for the hospitals to deal with, because then they only have to pay one entity as opposed to paying potentially 9 different ones. But I alluded to Access, that program, that could be a significant step forward for everybody. What Access is talking about right now, it's very preliminary, but they would talk about making the fire departments providers within their system. And that would create that payment model for the hospitals or the insurance companies to be able to pay us directly. So they don't have to have a contract with each city. So they could pay a cost per call, a cost per day basis. So that's going to be cutting edge. That's really tip of the spear. Nobody else, no other Medicaid's doing that I know of. So Access is very excited about trying to move that forward.
Councilman Holman.
Thank you. One of the things I was very excited about as you made your presentation was the fact that you're making a conscious and and concerted effort to put together a referral guide for people, because I unfortunately am in a situation where I do use your services frequently. Not too frequently, I hope, but and have had to for many years. And part of the challenge for I'm going to speak now from the patient side and not from the hospital or is that it happens to you. You don't know what to do. You can't get hold of your doctor in today's world because they're not like taking phone calls anymore. And you don't know what to do.
Yeah.
You know, who do I call? I was just in this situation a month ago when my with some serious health issues, and it was like, now what do? I needed help. And my kid stepped to the plate and helped me out. But I'm really excited about that because that's something that I think could alleviate on its own a whole lot of the trips to the emergency room, just simply because that's a quick answer, and you need a quick answer when you're in that situation because you're not, first of all, you're probably not thinking clearly. Many people that are in that situation are living alone, so they really don't have anybody to bounce what should I do off of. And I can see why we have people that are making 44 was it or something like that visits. So I'm really excited to hear about this as I've done some reading and stuff. I think it's a win-win-win, and that's important. But it also, when you're doing pilot programs and you have, when there's a movement like this across the country, at least, that you can get the pitfalls. Everybody doesn't have to hit the same pitfalls.
Right.
You can work them out as you're going through it, and you will share because everybody is excited about a pilot program. And I think that it leads to a great deal more success. So thank you for bringing it forward. I as you can see, I'm kind of excited about it because I live there.
Yep.
And so I understand why people are doing what they're doing. It sounds goofy. You think they must have some kind of mental problem that they'll just keep calling the emergency and go to the ER, but it's you don't know what else to do. So
And sometimes that's the only health care that people have. So.
Exactly. Yeah, no, it's a refreshing, I think, approach, and I sure hope it works, that we can at least try it.
Councilman Stipp. Oh, Brian.
Oh, yep, Mayor, members of the council. Just for the public that may be watching this, the name Stan has come up several times.
Yes, I was going to say
So
that.
Stan Holm is the CEO of Brazo West Campus, and he's actually here too. If there are questions specific to him, he would be available if there are any from council. But just wanted to point that out to the public.
Councilman Stipp's first. Okay. Go ahead, Councilman Stipp.
Thank you. Before everybody in the rest of the room gasps, I'm going to say it up front. I'm in support of this, but I do have some questions that I think we need to have.
Sure.
We need to have laid out ahead of time. This is a very important public policy decision. We're going to embark on the next frontier of EMS. So as a community, we're going to say yes to that or no. So we should really know what we're getting ourselves into, I think, before we truly launch the pilot. You're here today because we have a grant application due on the 22nd of January.
Yes.
The grant monies and the program will not start until July 1.
July 1, correct.
So between January 22 and July 1, is it possible for you to create very specific measurements for success? What you outlined isn't specific in any way, shape, or form, but for us to know what are we getting into, because in our city, once we start a pilot, we don't leave it. We're starting a new service. So if it's successful, we're going to feel the need to continue it. The community is going to want to continue it. The staff is going to want to continue it. So we need to be prepared what that looks like before it starts. So I don't want to stop the process from moving forward, but I think getting some specific measurements about what does success actually look like before we implement it will be very important for us, because will this come back before us to accept the grant like all the other grants do?
Mayor, members of the council, we would be looking for direction tonight to apply for the grant, because and then it would be due by January 22nd. We are not looking at coming back to council for the grant itself once we have that prepared. It's really getting that direction tonight to get it ramped up and submit.
So once we approve tonight, a lot of times we have to go back and we have to accept actually taking the grant.
Right. Councilmember Stipp, specific to this one, we're not looking at matches. But we would be looking at doing IGAs, working with other communities. That would come back to the mayor and council. And the IGAs would really be developed after the grant submittal or before. That's a fundamental question.
Yeah, the IGA would be developed after the grant submittal. It does not have to be added into the actual submittal itself.
Yeah, I don't want to do anything to slow it down or stop it.
I don't either. Yeah.
So, don't misread that. I'd like to see something before we actually begin it, because we can always turn the grant down. I mean, we don't have to take the money. The other partners can take over, but and I'm not suggesting that that's what we do. But I think we're owed some specific measurements of what does success look like. The other thing, just for a point of clarification, and you mentioned it, and I think I may have heard it, maybe not right. You're suggesting that this model of a two-person EMS response is the way that we're going to do things in the future?
No.
Because that's kind of what you alluded to when you talked about what happened in the 2006. So I want to make sure that we get that clear on the record.
Well, yeah. I mean, in 2006, they asked for us to look at a two-person response model to EMS calls.
Right.
Absolutely. That's not the fundamental question for 911. It's more for these follow-up visits.
Correct.
But I think it also gives us an opportunity to look at that model, though. We've really never been able to, without impacting the budget, really look at that type of a model to say, does it work? And where does it best work? Does it work better in the community paramedicine model, or does it work in other models? But no, right now we're just going to look at how that model works within the system.
Okay.
Community paramedicine.
So we talked about measures. We talked about the obviously benefit to the community. So in 6 months, so we have July, August, September, October, November, December. So January of a year from now, January of 17, you come back and you're ready to report out what the pilot looked like. What's the next? Will the next steps or the future of that be identified during the pilot?
Yeah. I think it has to be part of the pilot in order for us to be successful in it. Is kind of, can we create the sustainable model? And really, what does it look like? Can we continue on this regional partnership? Does that make the most sense for everybody? What's the feedback from the other cities? And then, do we have the patient volume to be able to hold up a program like this? We're hoping that within that year that we'd have more conversations with the hospital partners, and that possibly this other grant could come through with Tenet that would fund for a year. So I mean, there's a lot of possibilities out there that are just starting to cook.
And that's my last observation: is our local hospital is noticeably absent from this discussion. And I realize St. Luke's is they're funding a research kind of project,
Yep.
and how does this work? So I don't have an objection to that, but I think the next discussion we have, if we don't have our local hospital at the table at this one, I think we're going to have a difficult time getting this through the public. So Stan, that's heads up for you. What we need to, the benefit clearly is that in Abrazo, they will benefit the most by this if 90% of our patients go there.
Right.
And we're seeing their repeat customers. They're not going to get fined, and yet they're not contributing anything to it. So I think from a true collaborative partnership, we need to have them at the table.
Right, and then just full disclosure, we've been talking probably for about 2.5 years on both the behavioral health and the community paramedicine program with Stan directly. And certainly they're in a growth mode at the hospital. So high volumes, trauma center that's open now, that's contributing greatly to the community. But the hospitals, yeah, you're right. They need to be good collaborative partners.
Yeah, from the public policy perspective, we're going to put out the effort, we're going to put out the expense, and they're going to gain all the benefit from it. So from a public-private partnership means that there's a mutual benefit for both. If the public is only putting out the effort and the private is benefiting, then
I'm going to interject because I get to speak the last. So just as you're talking, no, I want to add to what yours is, and I just wanted. We haven't heard any of the risks this might take, and we have a litigious society,
Sure.
and I see that by sitting on the board. It's unbelievable what people sue for. And so that's the other side of it so I'm just adding it to some of the things that Bill said, and I'll turn it back over to these. Go ahead.
Do you mind Mayor, if I address that question? That's actually why we have Dr. Bradley here too, to help us through that piece. She's not going to allow us to creep outside of our protocols. We do have very specific protocols that we work under her license essentially for, so that creep outside the protocol cannot occur. What she talks about time and again with us is if you find that patient that's getting towards that point where they do need 911, then activate the system, even from the community paramedicine standpoint. We shouldn't be doing stuff that the 911 system would usually do for this patient. That should access the 911 system. So she's been a strong partner there at the table with us all along, keeping us in line, as a good doctor should. And we've also talked to Risk about this as well, and they feel like we need an additional rider for that because this is something that's a little different for us. So we're looking at the cost of that additional rider. Right now it's about $2,500 for the year, so not a huge increase in costs. We can absorb that within our grant itself or other funding sources if the tenant hospital comes forward with their grant. So
Thank you. Joe?
Well, a couple things. First, you kind of followed up on that. One question I had was, again, litigious, how's that covered? And you kind of hit that working under another doctor's protocols. So really you're working under her license on some of those questions. But the question I had, and again, this is not my area of expertise, is Stan's here. And I don't know if Stan would like to say anything about what he thinks about this type of program or whatever. If you would, Stan. Generalities, what do you think of this? Is this where we're going in the new Affordable Care Act? Do you see value in this? Where do you see partnership as far as working with other hospitals? Just share your views, because again, I'm not the expert on this. What your thoughts are on this?
And before the partnership we have during the pilot program, but I'd like to know after the pilot program. So I would like to know how much of a buy-in tenant would do to help the program. It would be less of cost to you if we're doing a partnership, but I would like to see that. So,
first, Mayor, Council, thank you for this opportunity to speak with you. I'd be remiss if I didn't mention to you that you have a great resource right here in your fire chief. He and I have been collaborating on this for quite some time now. And when we look at this, really healthy communities is something that's been around for about 20 years plus. It is something that we are looking at more and more in healthcare today in the acute care setting to look outside our walls. The reimbursements, has already been described in length this evening, is heading in that direction as well. A year ago, as we were talking about the innovative ways of how to fund this, a year ago I would have said I'm absolutely the only individual that should be responsible for funding that. In the last probably 6 months, we have found that the insurance carriers are interested in funding this. We have our hospitals are absolutely interested in funding this. We have the grant monies that are out there from a variety of sources that are available and accessible to fund this. And more, even primary care physicians are getting reimbursed by the federal government to have case managers to go out in the field that can also use a collaborative effort with what we can do with our community paramedicine. I can commit to you tonight that, and by the way, very respectfully, I would share with you your comments of post-pilot. This is a commitment from the council going forward, and asking those tough fiduciary questions now are appropriate. I can commit to you that as this should be successful, as we've seen in other areas, as Chief Louisi has mentioned, there's a lot of resources in the healthcare industry that would be committing those funds before we would look to come to cities for the funding for that. So I can commit to you tonight that you should feel confident that funding sources inclusive of Abrazo West, tenant through our other insurance locations, grant funding, pilots, additional pilots, what the federal government's looking to do, the access for Medicaid being a reimbursement he discussed. There are so many significant funding sources wanting this to be successful to keep patients healthy from coming back to the hospital. I can confidently tell you that you shouldn't have to look to any taxpayers to help fund this going forward from the pilot.
That's very reassuring, and that is one of our concerns. Now, what is the strength in having an RN with the team? Because I notice in some of the studies that's what they've done. And what is the knowledge of the RN compared to the paramedics? So I'm just want that. What is?
Yeah, certainly different types of programs have used different models. The feedback that I'm getting right now from the other city agencies that are doing it in the Valley, the one with the nurse practitioner in Scottsdale, they seem to have a higher level of care that they're providing at the patient's bedside. Now, nurse practitioners are licensed mid-level practitioners. They're above a nurse, but certainly they can see patients, they can bill for those. So they're kind of working through that program right now, but that seems to be working really well. With Tempe, the nurse, provides that consistent from St. Luke's Hospital out to the patient being discharged. They can follow their care almost from inside the hospital to outside. Talking with Dr. Bradley a little bit more about this, the feeling that we have right now is the medics won't be working outside of their scope, but could provide that same level of patient care and safety for the patient.
Yeah.
So, they don't feel like that it's going to have any additional value at this point in time. Now, something that is unique about Goodyear Fire, but I don't know all the other agencies that intimately, we actually have 4 of our firefighter medics that are nurses that are actually working as nurses on their days off. So we could tap into that resource if we ever found a need to be able to go in that direction to provide that care for the patient. But right now we're not seeing that need locally, but we'll continue to keep our eye on that to see if that provides an enhanced level of service for them.
Councilman Osborne?
One last question of clarification. So you mentioned that this 2-man crew would be committed from Goodyear,
yeah.
And the other one we're not real sure. It could be someone from Peoria. You said
Avondale.
So okay, but does that mean then that these calls are going to Avondale and going to Goodyear? I mean, is that how you're splitting it up, or is it going? So I.
Yeah,
please,
our concept, our early
understand.
concept at least, is that we would have one south unit and one north unit. So the north being Surprise, Sun City, and Peoria. The south units would be Avondale and Goodyear. So what we've done is we've had our partnering agencies start to pull all of their frequent users using that definition, 3 in a month, 12 in a year. And they can pull it by address. And we would proactively go out and visit those patients. Now, Goodyear we know has 44. Avondale may have, I'm not sure, 50. So amongst the 20 hours a week that we'd be in service in the South unit, we'd go out and visit those patients over those 5 days. So we wouldn't really be extending much further than the Avondale or the Goodyear borders. And then the Peoria would handle the Peoria, Sun City, and Surprise calls as well, their unit up there.
Well, the combination does bring a question in then if the hospitals are going to help sustain this financially. Now you've got Banner, right? And then you've got tenants, or Brazos. So there's another complicated division to try to contend with.
Right.
And that will be because they're competitive.
I will share with you, though, if it's okay, that this is a collaborative effort that even outside our walls in competition, we come to common ground.
Okay.
And for example, in Buckeye with Chief Costello, he did that partnership with Banner Australia for patients that reoccurred to their emergency departments. But he and I have already been speaking about the patients that he sees in Buckeye for our hospital. And even this morning, back to the behavioral health issue, I met with Deb, who's the CEO at Banner Thunderbird, who has a behavioral health unit. And while they're looking to expand that, right now they only can accept about 30% of the patients on demand for behavioral health. So she is also interested in coming to that behavioral health summit. So there still is collaboration even beyond the competition among the healthcare systems.
Thank you.
One last question.
Joanne?
This also is including Litchfield Park. Does that go to?
Yeah, we actually had them run the Litchfield Park zip code as well for the patients. So yeah, included in that.
Yes, Councilman, do you know? No?
No.
Everybody have all their questions out?
Stan answered my question.
All right. Well, thank you, Stan, for coming forth and giving this information. And, I feel confident sitting on the board with a Brazo tenant. I can see how the changes in the hospital, the caring, and so there's a big trust now that goes out to your hospital, and I congratulate you on that accomplishment. So I can see the two components working well together because you see them frequently, right?
Too frequently, probably.
You already have sort of a partnership. But I think we're all looking, all these questions that you gave that were presented tonight, I think they're looking for some answers as we go along to be assured that we know what the cost is going to be. because we have to talk to the citizens. And there's some citizens that, there's a certain age group that doesn't go to doctors now, doesn't have insurance because they feel like they don't need it. So you may have that comments from people that are not.
Yeah.
So,
Yeah, and absolutely. I mean, we hope to answer all those questions within this pilot project.
yeah, and keep the public informed.
Yes,
All right?
absolutely.
Thank you very much.
Thank you.
Thank you.
Okay, I have to ask you, we have meetings coming up, open.
Yes. Excuse me, Mayor. Frog in my throat. Mayor, members of the council, so just to be sure, there is no vote on this tonight, but the direction that we have received is we would be going forward with the grant. So just want to make sure that is understood. That's the direction that we've seen.
Right. Okay,
Okay, thank
fine.
you.
Okay, so we're going to adjourn this meeting. We're going to begin the regular meeting. This meeting's adjourned.